So welcome back everyone after lunch, hopefully feeling refreshed. This is Breakout Session 6 on responding to the public health emergency of COVID-19, what we've learned about new approaches to data management and challenges for the future. And your co-chairs for this session are myself, Jill Pell, Director of the Institute of Health and Wellbeing in Glasgow University, and Peter Bradley, who's Director of Health Intelligence and Public Health England. And what we hope to get out of this session is to demonstrate how we've developed new insights from routine data, community data, and real-time tools in informing our public health response to COVID, what immediate lessons we've learned in relation to COVID-19, but also looking forward to what we've learned about data and infrastructure requirements in terms of future public health challenges. And we've got three eminent speakers who represent the 4 nations. Ronan will cover what's been happening in Wales and Northern Ireland. Then we have Julian on England and Scotland covered by Helen. And the format is the same as the other breakout sessions. The speakers will speak back to back for 7 minutes each. We'll hold off questions until everybody has spoken, but it'd be really helpful if you could upload your questions during talks onto the Q&A session. If you want to direct your talk at one speaker in particular, please let us know in the Q&A box. And bear in mind that it is open access, so please don't post anything inappropriate. And at the end of the session, Peter will sum up. So over to our first speaker, Ronan Lyons. Ronan is Clinical Professor of Public Health in the University of Swansea, and he's also Director of the HDR UK for Wales and Northern Ireland. So over to you, Ronan.
So good afternoon and Pnawn Da. Thank you very much for this opportunity to describe what we're doing, particularly in Wales, from a data perspective to control the COVID epidemic. So if I just move on to the next slide. So being a reluctant academic, when the scale of the COVID challenge became apparent, I offered the services of the HDR UK Wales team to provide insight through linked data to the Chief Medical Officer, Frank Atherton. And Frank quickly took up the offer. The next day I found myself on the Welsh Government COVID-19 Technical Advisory Group, and within a week I was sort of leading the data linkage exercise for Wales, Welsh Government and the NHS. And some of our findings, they feed into SAGE. So our focus has been on supporting Welsh Government and the NHS Wales, and hence we've neglected academic publications. I'm sure that will come back to haunt us at some point in time. So following the One Wales approach, which is adopted throughout Wales, we created a multidisciplinary, multi-agency team from all those organisations which are listed on the slide. And very recently, we've added in the Royal Society Delve initiative to add to the analytical capabilities. And again, if I move on one more slide. So here is a sort of a collage of the pictures of some of the team. I didn't manage to get them all. I have to say they've been absolutely brilliant. Everybody has worked extraordinarily hard under a lot of pressure. And their contribution has been rightly regarded very highly by Welsh Government and all the organisations in Wales. And again, if I move on to another slide. So what we did was to respond to the challenge. We leveraged the learning that has been developed from the Wales Multimorbidity Cohort, which is funded by HDR UK and the MRC. And we used that to create 2 total population cohorts. So C20 contains everybody alive in Wales on the 1st of January 2020, that's known to the NHS. And C16 is the counterfactual cohort that contains data on the entire population between 2016 and 2019. So creating the cohorts meant we had to bring together data from many different sources and use that to understand what's happening in the population, and also provide a capability of guiding and evaluating interventions. The response to COVID has enabled many trapped data sets to be released, as I'm sure is the case right throughout the UK. There are many of these that will be used for the first time, but I point out particularly to the list that I have here, complete census linkage, which has been agreed within a month. linkage to electronic staff records from multiple sectors, viral genomics, the inclusion and update on a daily basis of all test results, and the Zoe app as being particularly helpful. And I'll go into a couple of those in a little bit more detail as I go along. So next. So earlier in the introduction, Patrick Vallance highlighted the need for spatial data to understand and control local epidemics. And we're now moving to another phase where longitudinal cross-sectoral data linkage will provide the insight into transmission between networks of individuals who are nested in homes, in hospitals, in care homes, schools, and in other sectors, as emphasized by a diagram on the right here, created by Richard Fry. And rapid analysis will help us to inform the decisions on how we exit sectoral lockdowns or whether we need to reintroduce them, and also help with the evaluation of control measures using a fusion of data linkage and case control approaches. Next. So officials from many departments of Welsh Government have developed a set of 26 questions where they thought that data in sale could provide valuable insight. There isn't enough time to go through these in detail, so what I've done is just to include a number of visualizations in this slide. So the first diagram is an example of a visualization of patient pathways for people who have been infected with COVID, what they were like before that, and what they're like afterwards, showing these pathways, their activity status, and their outcomes. That is updated weekly into the CMO briefing document. Below that, there is a survival curve, and what that does is to clearly demonstrate our failure to protect vulnerable people in care homes. You can see here the survival curve is basically survival of people in care homes on each of the years, and the fairly massive difference that happened once lockdown began in 2020 is evident for all to see. And finally, I've included a couple of maps from the Zoe app data available through the sales system. These are Bayesian smoothed maps. They're created by the HDR UK Breed Hub in collaboration with Peter Diggle and the HDR UK Wales team. They're updated weekly, fed into the CMO and other groups that actually show us how the predicted hotspots are moving across there. So finally, I'd just like to pay particular tribute to all of the people in the team who've made this happen. And I'll stop there to give some time for questions. Thank you.
So thank you. We're moving on to Helen, is AXA Chair of Medical Informatics and Life Course Epidemiology at the University of Edinburgh.
Hi, so I'm speaking today on behalf of my colleagues in Public Health Scotland. I am an honorary consultant in public health Scotland. And since the start of the epidemic, I have been co-leading the modelling and research cell within Public Health Scotland. A bit like Ronan, that came about because I sort of offered my services early in the early days of the epidemic to see if I could make any useful contribution. Next slide, please. So I'll just give you a little bit of idea about the infrastructure in Public Health Scotland. One of the things that was really great fun was that Public Health Scotland came into being several weeks into the pandemic, having previously constituted ISD and Health Protection Scotland. So they're now in one umbrella organisation called Public Health Scotland. And there are four main programmes in response to COVID in Public Health Scotland: the Clinical Response and Guidance Programme, the Contact Tracing Programme, Social and Systems Recovery, and then this one, the Intelligence Research and Development Programme. And within that, we have real-time epidemiology, enhanced surveillance, and modelling and research. So real-time epidemiology does all of the daily reporting. Enhanced surveillance, as you might imagine, involves both ongoing reporting, but also de novo data collection to inform surveillance. And then the modelling and research team, I'll say a little bit more about. Next slide, please. So within the broad scope of the Programme of Intelligence Research and Development, the function is to provide ongoing, accurate and timely data on the transmission, severity and direct impact of COVID-19 on the Scottish population, and to inform decisions regarding prevention and control measures. Next slide. And as you can see here on the left, there's a wide range of different data sets that are drawn upon to complete these functions, including ECOS, which is our National Virology Laboratory database, which captures all nucleic acid tests for COVID-19. RAPID is the daily returns of hospital admissions. SIGSAG is a database that captures all critical care unit admissions in Scotland and reports in on a daily basis. And then we have, of course, death notifications and then other sources of data, including seroprevalence studies and so forth. And indeed also, as in Wales, work ongoing on sequencing of the virus to enable greater maps on transmission and spread of disease. And the outputs of the IRD programme are daily reports to the Scottish Government and to the health boards, weekly reports, and then further downstream briefing papers and reports and academic papers. But our focus has been very much on trying to do policy relevant analyses straight off the bat. Next slide, please. So there are many key questions that we tabled across different parts of the organisation that needed to be addressed very quickly. And I'm going to focus for a few minutes on the last of these, which is what are the risk factors for severe COVID-19 disease, and give you just a little bit of under the bonnet information on how we approached that. So next slide, please. So when we set up the modelling and research cell, we quickly realised that we would need to get together a comparative population. First of all, we need to collate together the cases and the information in the cases, but then we'd also need a comparative population from the background population. Unlike in Wales, where you have the full population data set available to you, the most pragmatic way for us to achieve that actually was to set up a case control study. And we can talk about the reasons for why you do that route if you want in the questions and answers. But essentially, we decided to ascertain all the severe cases as those testing positive in the ECOS data set, and either entering a critical care unit or dying within 28 days of a positive test, regardless of cause of death in the death cert. At that time, the NRS deaths data weren't coming through as quickly. We now do have access to the NRS deaths data. These are the additional deaths where somebody has never been tested, but where there's a mention of COVID-19 on their death cert. But for this initial study of the case control study, we were focused on test positive severe cases. We took 7 age, sex and GP match controls per case. We linked to a series of data sets that I've already mentioned. The one I didn't mention before is PIS, which is the Prescribing Information System of Dispensed Prescriptions in Scotland, and SMRO1, which is the Hospital Admissions database that contains ICD-10 coded discharge categorizations. And the methods primarily were conditional logistic regression. And we also were keen not only to describe the relationship of various risk factors to outcomes, but also to get an initial handle on approximately how much information you might hope to extract from clinical records to enable prediction of severity. The reason that we were doing all of this is because we wanted to understand a number of things, including as we move out of lockdown, is it possible to delineate with better predictive performance those that are most at risk of severe disease that might, for example, require special measures. Next slide, please. This is just a graph to show you the incidence of severe and fatal COVID-19 in Scotland. And this isn't the place to go into the nitty-gritty of the detail, but I would just draw your attention to, if you look at the fatalities here in the dotted line, you can see it's pretty much a straight line on a logit scale, with a very clearly higher rate of severe disease in males and females. And essentially what this translates into is about a 3-fold rate ratio for every 10 years of age in the age range 40 up to the top of the age range of the population. So it's quite interesting that that is really just a straight line in a logit scale. And then this, these other lines are for critical care unit or death, and you can see that there it's not quite as steep a slope, reflecting to a certain extent the differing age distributions of those who enter CCU versus those who actually ultimately die. Next slide, please. These data, incidentally, are on a preprint on medRxiv. What you can see here on this slide is that what we were trying to get a handle on is just how many of the severe cases already have some well-established condition leading them to have increased risk. So we pulled out various conditions like type 1 and type 2 and unknown type of diabetes, ischemic heart disease, other heart disease, asthma and COAD, chronic kidney disease, and certain neurological conditions that lead to paralysis or immobility, liver disease and immune deficiency. And you'll see that these loosely map on to some of the moderate risk conditions that the NHS and PHE and PHS sites already list. And the key message from all of this is that overall 74% of the cases had one of these established listed conditions in comparison to 48% of the controls. The other thing to note, of course, is that 48% indicates to us how just taking simple binary risk groups and assigning them to risk will massively overestimate the risk for many people, of course. You can see that among the younger age group, an important thing to demonstrate was that actually, despite the reports in the press of COVID striking totally healthy individuals like meteorites, this isn't really the case. The vast majority, even in the younger age group who have had severe COVID, either have a listed condition, and even when they don't, they have a substantially higher rates of prescription in the last 9 months to people who have not of the same age in the background population who haven't developed severe COVID. So they are clearly, broadly speaking, not a clinically healthy group that have suddenly been struck down, but they do have predictable risk for severe COVID. Next slide, please. And this is just to give you an idea of some of the rate ratios. I won't drag you through all the details of the numbers. You can look up the paper on medRxiv, but you can see the overwhelming rate ratio associated with care homes, as Ronan has already pointed out. What you can also see is that in a multivariate analysis, when you adjust for listed conditions, having any prescription and having any admission in the last, any prescription in the last 9 months and any admission in the last 3 years clearly are predictive above and beyond the listed conditions. Next slide. And if we compute then the predictive performance of, and this was just a very, very, by no means throwing the kitchen sink of machine learning as prediction here. This was just a very simple stepwise modeling procedure with 4-fold cross-validation. And it was just to get an approximate idea of, you know, is it worth trying to extract information in a more formal modeling process? And you can see that if you put in the demographic factors, you have a C statistic of 0.716. It increases with listed conditions, and it increases further when you put in an extended variable set, which included all ICD-10 chapters and all BNF drug chapters, for example, that people were exposed to. And so our conclusion really from this work, I mean, there's lots of different bits of information that are useful in it, but one of the key points is that a risk classifier that uses all the information available in health records, rather than just trying to use some crude algorithmic binary-based allocation of risk status to people, should more accurately discriminate between low and high risk individuals who may require shielding or special measures until the epidemic is over. I think this is becoming an increasingly important issue as we relax lockdown measures. How do we best protect those, and not just those with the extreme conditions requiring shielding, but also those in the upper part of the distribution for risk in our society? And I will stop there. And just last slide to just acknowledge other folk. There's more work in development, including David McAllister, who's doing a lot of work on healthcare workers and care home residents at the minute. And lastly, this is just the programme and acknowledgements of the great many people across the team.
Okay, so thank you very much, Helen. So Julian Flowers is still Head of Data Science at Public Health England. So over to you, Julian.
Thank you very much. So I call this data in the time of COVID. I'm basically a jobbing public health consultant, and my normal interest is in non-communicable disease. So I became involved in the COVID incident about halfway through in March. And in my day job, I manage a large repository of routine data. We do a lot of health reporting, and we're trying to build some capabilities and skills to do data science. So this is a bit of my perspective really about what we've had to do, certainly in sort of conventional health intelligence, to respond to the incidents, and how we've had to radically change the way we do things really in order to support the incident. Next slide, please. So obviously data is hugely crucial. And what I wanted to do is just talk about 5 areas of challenge. So I haven't got a lot of data analysis. It's much more about process and I've chosen, I could have talked about more, but these areas are linked. So I want to talk a bit about the way we've had to manage data, issues about access, data linkage, then public reporting, and finally workforce development. So next slide, please. So the incidents like this are hugely complex. There are multiple stakeholders, there are multiple flows of data, and one of the big issues has been, you know, in a complex organisation, large organisation like Public Health England, we have different opinions about how to do things. So we've had to overcome lots of cultural barriers. And then during the incident, we've had lots and lots of data stores and flows being set up. So we don't have a kind of single system. So there's lots in PHE. SDSSR is our case database. We have a big data lake. We have the track and trace data is going into Amazon and so on. But we've also been encouraged to use this NHS system called Foundry, which is a fantastic all singing, all dancing system. And NHS Digital have set up a new data access environment. We have the Joint Biosecurity Centre, which is trying to set up an environment, and so on. And all of this is underpinned by daily flows of data going all over the place. So for somebody who's unfamiliar with these data sets, trying to rapidly get to grips with it, it's been quite a challenge just to understand where things are going. Next slide, please. And to illustrate this, on the left, so one of the key data ingesting points in the incident in Public Health England is the epidemiology cell, and this is just one of many pictures which show how data flows through the cell and the sorts of things they do with it. And on the left, so on the right, is some of the data sets that are available to us in the data store. And then if you have the next slide, and then finally, we've been given this, NHS Digital have given us an environment in which to work, which is Databricks. And the reason I'm showing you this is that in order to access this, you have to have SQL skills, you have to learn how to use Spark, and you have to be an R programmer or a Python programmer. So, so it's not available for the jobbing analyst. If you have the next slide, please. The second issue is that lots of access requests, lots of multiple data sharing agreements, but actually it's been quite difficult to get consistency in data sharing, even within the same organization. And so we have a lot of demand from local authorities for data, and there have been some real difficulties with that. There's quite a lot, obviously there's a lot of control on publication, and at the moment there are any number of dashboards being developed. So it's quite difficult to know what is being produced. Have the next slide. And related to all this is that me, in my team and in PHE, we haven't had an environment like SAIL, and we don't have a Scottish health index. So data linkage has been a perennial problem for us, and suddenly it's become incredibly important. So we've had to set up very rapidly data linkage services. We're having multiple data enrichment sort of type approaches to data linkage, or building outcomes into routine data and so on. And that, you know, for my team, from a standing start, we've had to learn how to do this. We've learned heavily on our cancer colleagues and our communicable disease colleagues, but we haven't had a mutual familiarity with all the data sets that need to be linked. It's been quite a massive collaborative exercise to get to a point of data linkage, and we're doing it daily now. So it's been quite an impressive achievement to do that. I can have the next slide. And then related to all this is that I personally lead our public reporting system. We have a dashboard on Gov UK, and there is unprecedented interest by the general public in having the data reported. So we have this dashboard. We've had about 180 million page views since it was launched in April, and we have 600,000 data downloads. It's quite a limited set of data. It's been quite hard to explain to the public because it's very complex. There's different pillars and all the ways of different testing and so on. That's been a real challenge for us, and we've learned a huge amount about developing a sort of daily surveillance dashboard like this, and about how to sort of address public requirements. And if you just go to the next slide. And we've so much so that we've had to completely redesign the whole thing in order to add new data, partly because we've had hundreds of emails from the public requesting certain things, and from our politicians and so on. So we're about to launch the next version of that next week. And the reason that's important is that this is built in real time, so it takes daily data, and so making sure that it reflects that the numbers are consistent across the system is a real complicated issue. Can we have the next slide, please? And so we've also learned a lot about daily surveillance. So even very simple count data like we present is complicated because of the way that the systems work and the data flows work, and the difference between when an event happens and when it's reported, and the different impression it gives you of the epidemic curve and so on. And we're having to report UK data, so we have some variations between the four nations about how these things are done, and reconciling those has been interesting. Can we have the next slide, please? And then finally, all of these things have been a challenge for both people who have come from a non-communicable disease background. We've had to rapidly learn lots about communicable diseases and the data sets. We've had to learn these new environments, and our colleagues in health protection are rapidly having to learn new skills. And one of I think we've definitely got, for future, there's definitely shortages in sort of in development, in software developments, in using Python. So development of our workforce, our analytical skill set is I think a really important issue. So just 2 more slides. So one of the things that COVID has done is accelerate a huge amount of things that were already happening. As I say, we've had to do, we've moved our whole health intelligence operation from monthly monitoring to daily surveillance and monthly monitoring. We are using considerably more data sets. We had some pipeline developments which we've had to accelerate rapidly to make all this possible. We're moving our data. We've had to move a lot of data into open source for data sharing, and our website is fully open source. It's all on GitHub, and we have members of the public contributing to its development. We've had to join up a lot of working and build, and we have all these real-time data flows that we never had before. And these are sorts of things that actually give us huge opportunities to continue to support COVID, but also for the future. And the final slide. And in the cell structure that we had in PHE, we didn't have a data work stream, so we've had to set one up. We are basically consolidating a lot of the work as we go along in order to try and make it sustainable, so that we should be able to do much wider data linkage in the future, and to make better use of the technology. We really need to build data science skills. In our division, we have taught a lot of people quite a lot of things, but there's a massive analytical workforce in PHE, and we need to really upskill it. And we need to be able to automate things very quickly, because there's, it's still quite a lot of labor-intensive processing of data and that goes on, and it increases the complexity. So I think my main lessons are consolidate what we've done, automate, innovate, and upskill. Thank you. That's me.
Okay, so thank you very much to our three speakers. That was really interesting. And thank you to those who've already posted questions on the Q&A, and please keep doing so. So in the interest of efficiency, I'm going to combine two different questions. So there was a question about access to social care and other non-health data, and also a more generic question about what do you think is the main missing piece of the jigsaw? What data would you love to have that you don't currently have? So just going through the three speakers on those questions. Ronan.
So social care data, we have a certain amount of it in SAIL. We have got care home residency linked in. We're about to get data on the testing in all of the care homes, links to social care workers and other groups. We don't have in there, if you like, clinical records from care homes. And there are some local authority data sets coming into SAIL, but making sense out of them takes a lot of time because of the lack of standardization of social care data across the UK. I'd like some data sets a bit speedier. The obvious one are the coded hospital admissions for us, which are a month behind when they get coded.
Okay, Julian?
Yeah, so so we don't really get social care data in the same way. I mean, because it's all mainly locally collected, there are no strong national systems. We have care home data, we have some flows from CQC, and we also have increasingly community care data sets that are flowing. But there's actually quite a lot of work going on social care at the moment. What was the other question? What would you like?
Yes, what would you like in an ideal world? What's your...
So a big gap for us has always been GP data, general practice data. That probably will be addressed. There's a plan to flow GP data on a 2-weekly basis. So we have bits of GP data, but there's no kind of national data flows, no kind of HES for GP general practice. But that is actually being addressed, as I say, and that could be hugely valuable. One thing I just should add is that one thing that COVID has done is it's sort of the data sharing regulations have been enabled quite significantly to facilitate some of this to happen.
So Jill, I wondered if we might build on that slightly and pick up the questions around what this means for the future. So there's questions in there about has the formation of Public Health Scotland helped or hindered the response, and also what do you think we can learn from the many alliances that people have talked about that have been built up during this process that we can take forward for the future, for the management of outbreaks and other public health issues. I wondered if maybe the speakers would like to respond to that. Maybe I could start with Helen.
Okay, I'll answer the last question as well. Our biggest need right now is primary care data. I should also emphasize that in Scotland there is another initiative that is creating a research data platform for COVID-19, which will be hosted in the Edinburgh Parallel Computing Centre as part of the National Safe Haven. That's being led by really a sort of trans-institutional group of people, but I'm not aware that it's actually got, I don't think it's at the stage yet for people to actually log in and analyze data or anything. So yeah, definitely primary care data is big need. There's a lot of governance issues around that and negotiations happening, and hopefully that will be opened up a little. In terms of the merger of the creation of Public Health Scotland, well, I literally just joined Public Health Scotland on about the 7th of March, in fact, just before it came into being. My impression is that it probably does help interconnectivity, that there is now a clear umbrella organisation. So I think it's probably a good thing, a positive thing, and it has probably actually been useful. There's a lot of cross communication between ISD and Health Protection Scotland. I'm sure there was before, but I sense that it's increasing at pace. And you had another question, I believe?
No, I think that you've answered that really well.Maybe I could go to Ronan and for his reflection on what we need to build on for the future.
Yeah, I suppose I've got myself into a lot of trouble over the years, but I just do it anyway and ignore all organizational boundaries. And what you do is you find people who want to work together and just go and do that. But the bit I will pick up on this, because there was another question about PPI in this, in that, so that when you do things through sale, the public get to see everything and agree on everything. As well as that, in the Wales multi-morbidity cohort, we have 2 members of the public who are engaged in this, and we currently have a bid in to actually increase that to 5, including members of unions. And that's particularly important as we look at the risk to workers and how the intervention and control strategies are working to protect them.
Thank you. Did you have any further comment, Julian, what we need to build on?
Well, I guess we've had 3 really kind of successful sets of partnerships. So one is in England with other government departments. We've built very strong relationships with certain parts of and there's been a real cultural volunteerism. So we've had, as Ronan was saying, we've had some of the things we built, we put out calls across government. We've had people from all different parts of the government come and help us with certain things where we have skill shortages. So that's been really valuable. It's actually strengthened. PHE, is a kind of interesting organisation, and there's a lot more collaboration across the whole body analytic inside Public Health England, because we had several kind of much more siloed. And we need to keep that going. That's definitely a thing. And then we've had sort of various ad hoc research partnerships springing up. And I think, as Ronan says, it's a coalition of the willing. Often, if there's somebody out there who can do something. And as I said, we've had members of the public helping us build our public-facing website, which has been a very interesting experience. And it's amazing how willing people are to do that.
I would like to make a comment actually about these partnerships. All right. So one of the things that for me has been most gratifying about this experience is rediscovering my life as a more proper public health doctor, I would say, as somebody who normally is very much in academia and so forth. And it's been very exciting and interesting. But I agree with Julian that there's a sort of a revolution that's taken place out there in the world of data, of people using Python and R routinely. And importantly also, actually, people having verifiable research pipelines and using our Markdown as a standard or some other equivalent, so as to ensure really good traceback and getting code on GitHub. And for many of us, those are standard approaches these days to data analysis. But I don't think they're only just beginning to happen in the public health agencies in a way. And I actually think that what we need to do is to try to regain something that we have lost over the years, which is a better interconnectivity between the academic sector in public health and epidemiology and those working in public health organizations.
Yes.
And I think we can all benefit from that.
Okay, so just moving on to another topic. There are lots of questions, and it's really about flexibility of our whole data infrastructure. So the specific question was originally for Helen on ZigZag and whether it copes with the fact that we've changed whether particular bits of the hospital are labelled critical care and set up critical care units outside of hospitals. Equally, testing's been delivered by the lighthouses as well as normal NHS facilities. And also we really need data across the whole UK rather than look regionally. To what extent are we able to deal with those sorts of flexibilities and what needs to be done in the future? So we'll start with Helen.
Okay, to answer your question, ZigZag, yes, it incorporates data from both intensive care as combined intensive care high dependency units and HDUs that are so that's one question. The next one was?
Similarly, we've had testing with the NHS
okay.
Lighthouse.
Yeah, so Lighthouse testing, as of actually yesterday, started to find its way into the ECOS database. So the data capture for that it took some time to get properly flowing in, and as of yesterday, it will now be capturable via ECOS.
That's great. And Julian, you referred to the need to try and capture data across the UK when we're set up in different ways in different places. What are the lessons there?
Well, so we talk a lot. I mean, we have to, and we have to. Next week we're going to publish. So we've been asked by Number 10 to publish the UK data that's sort of presented at the daily briefings, and just trying to get those data flows sorted out and get agreement. It's just a lot of talking to each other, and that's a good thing. Emily, it would be nice if everybody did things the same, but I think that's never going to happen. I think we just have to embrace the diversity, and you know, and just all agree, you know, and just be clear about what it is that we're representing and reflecting.
Okay, and Ronan?
Yes, no, I agree with Peter said. The reality is you've got 4 devolved health organisations. Things are not going to be absolutely the same. The important thing is to standardise as much as possible, and to actually set out a system of federated TREs so it's possible to query UK-wide data from anywhere.
So what's a TRE?
Trusted Research Environment.
Oh, right, okay.
Okay, Helen, it's a very technical mathematical question from Peter Diggle. I don't know if you want to deal with that directly or educate us all on mathematical methodology. Oh, you're on mute.
I was actually just typing an answer to Peter there. So no, Peter, the answer is that although we thought about doing things like fractional polynomials and so forth that we've used in other settings before, for this particular report, we've just kept it really, really, really simple. We just chose the default spline that was consistent with a monotonic relationship. But happy to hear some suggestions from you about how you would, what you would do to model that more finely.
I think we'll maybe take that one offline because the rest of us won't be able to follow the conversation. Okay, so, hand over to Peter.
Yes, well, thank you to all the panelists for giving us such an incredibly interesting discussion. And for me, at least, I've heard the the real complexity that we've dealt with and managed and brought forward to help make some practical decisions. So that relates to the data sets, to the types of information that we've brought together, whether it's spatial information or cohort information or many other sources. We found some new alliances, and it sounds like that some of those are things that we really want to build on, and new ways of working as well, which have created new possibilities for us. So, for example, real-time reporting has been given a real focus in all this. And we have managed complexity in other ways, cultural and data flow, sharing, linkage, the way we give information to the public, and workforce gaps and skills that we now want to actually enhance for the future. So above all, it sounded like the importance of collaboration was the thing that we really believe in and we want to have for the future. And yeah, I guess if we're feeling tired, we probably know why now. So thank you very much. I think with that, Jill, we can probably say this session is ended. So I think I'll hand over to the coordinator of the event if they've got any messages to give. Or otherwise, I think it's just a question of linking to the next session.
Yeah, so David Seymour here. I'll just, very briefly, thank you very much indeed to everybody for taking part in that. Thanks also for a very active Q&A. And so we'll hopefully, well, the recordings will be on the website. Exact timing depends on how long it takes to process these things. The next breakout sessions start in a little over 10 minutes. Your link should be in your program, your delegate packs, but you've got an extra couple of minutes to make a cup of tea. We'll look forward to seeing you in the next breakout. But thanks again to everybody for their participation.